Okay, here we go. This is the 2016 Next Step, Chapter 7, Digestive. Starts out with a little wordy stuff. This is kind of the flow of the digestive system from top to bottom. 7.1 is an inpatient consultation. Talks about a patient had an ileocecal resection 4 weeks earlier. Now that patient has a chronic bowel obstruction. So this is a inpatient consultation code with a bowel obstruction. 7.2, this is an anal fistula. It talks about, or some of these fistulas talk about, they call the fistula a sinus tract. Don't get that confused with the sinuses on your head. If you're dealing with this body area, if there's potential abscesses or fistulas, then they may very well be calling them sinus tracts. Buttocks, rectum, anal areas, you kind of get that sometimes. Now, what a fistula is. A fistula is a tube tunnel of infection that kind of fills up with pus, purulent material, that kind of stuff. So typically those areas are inflamed. They need to be incised, drained, maybe even packed. Just depends on what's going on. So 7A is an anal fistula. This is a perianal fistula. It's elective fistulotomy. Otomy meaning it's the action, meaning incising or incision. And then over here at the 4 o'clock position, think about a clock. So a 4 o'clock position would be down here. 4 o'clock position, they found an indurated mass. They drained it, and they're good to go. 7.3, intersphincteric abscess. Again, we're in the same body area. Intersphincteric abscess is going to be your diagnosis code. They talk about it being in the 6 to 7 o'clock location. I don't see them calling it sinus tracts yet, but you may still encounter that. But make a little note about that. 4A, perirectal fistulectomies. Ectomy is a removal. Otomy up here is an incision of. So an ectomy is a removal. This is perirectal fistulas. Patients coming in, they've had these issues in the past. They're calling them fistulous tracts. That's kind of like a sinus tract. They're still in this rectal area, and that's what they're talking about, is a tunnel of pus or some kind of infectious drainage going on. 7.5A is a hemorrhoidectomy. We're getting into different hemorrhoids. This wordy stuff, it's a terrible picture. This wordy stuff kind of tells you what to look for when you're going to find your diagnosis code, the different grade of hemorrhoids. You need to know if they're internal, if they're external, are they thrombosed, are they bleeding? That kind of information is what you need to glean out of the record or abstract out of the record in order to get an accurate diagnosis code. This particular hemorrhoid, I always go to post-op diagnosis. It's an internal hemorrhoid, grade 2. They're performing a hemorrhoidectomy. Everything that I could tell, there's only one single hemorrhoid, so there's only one CPT code. They excised it, and it's good to go. It's a pretty easy read. Make sure your diagnosis code has that second-degree hemorrhoid. Catheters, 7.6. This is an op report putting in a peritoneal dialysis catheter. Remember, there's two kinds of dialysis. One in the abdomen called peritoneal, one in that's hemodialysis, and that's where they put the AV fistula in. So this one is for end-stage renal disease, and the peritoneal dialysis catheter is being placed in the abdomen. They talk about the peritoneum and all of that. So this is pretty straightforward. In endoscopic procedures, gastritis and duodenitis, or duodenitis, however you pronounce it, wherever you're from, ulcers. This is all kind of diagnostic stuff that you may want to make some notes about after you read it. Your rectal procedures here. A reminder, anytime we start getting into colonoscopies, sigmoidoscopies, proctosigmoidoscopies, if your physician says he's performing a sigmoidoscopy, and you see that they've gone all the way into the transverse colon, then you would not code a sigmoidoscopy, you would code a colonoscopy, because you have to code the furthest extent. Always code the furthest extent, and that's what this is telling you right here. So here's an EGD, esophago-gastro-duodenoscopy, so they're going into the esophagus. Gastro is stomach, duodenum is the top part of the small intestines. This patient has, according to the post-op diagnosis, has mild gastritis, mild duodenitis, gastric ulcer, not actively bleeding right now, and a hiatal hernia. This particular diagnosis codes, we're going to code it to bleeding or hemorrhaging. Hemorrhaging kind of equals bleeding. It sounds really terrible, but a lot of times it's hemorrhage could be the same as just some bleeding, active bleeding. Typically, we do not code unless we see active bleeding. In this particular instance, they do find coffee ground material, which indicates fairly recently something's been bleeding. Although they didn't find it bleeding at the time, they had evidence, enough evidence, not just a few specks, but they found enough coffee ground material that I would code this as bleeding. So you'll have your 1 CPT code. You've got your gastritis bleeding, your duodenitis or duodenitis bleeding, and you have your ulcer, stomach ulcer bleeding. Now, the reason we make all 3 of those bleeding is because we do not have any, no indication, documentation that it's just the gastritis or it's just the ulcer that was bleeding. It probably was just the ulcer, but we don't know that. So you make them all bleeding so that it's consistent, unless you have some other kind of indication that only one of those diagnoses were making it bleed. And then you've got your hiatal hernia, which is just kind of a gimme in here. 7-8, this is a colon polypectomy. They're doing a colonoscopy with removal of polyps. You have to, you see in the pre-op, they said polyp on sigmoidoscopy, but they actually advance all the way to the cecum. And if you look in the front, I'm going to open this up. Hopefully I won't screw up the you know, focusing. Sorry, I probably just screwed it up by doing that. I think there is it in here? There's a good picture of the colon that kind of shows it L-shape, or yes, here it is. Okay, so let's look at this for a minute. When you're taking the board, please, please, please be familiar with these pictures, because even me, I've been a nurse for like 210 years. I still come back just to make sure that what I think I know, I really know, because you get nervous on the boards. You kind of forget what you thought you used to know. Maybe, I don't know. So here is a really, really good way to know the different parts of the colon, very specific to your scopes. So here would just be the rectum part. Remember the S shape? The S shape here would be your sigmoid, and then you get into your descending colon. Your splenic flexure, flexure just means turn. Splenic means your spleen's sitting right up there. Then you have your transverse colon, just going across, horizontal part. Then you have your ascending colon, because if you do it opposite, it would be coming out this way. So you're going up here, you're going across, you're coming down. But when you work it from the anus, it's opposite. So that's why it sounds a little weird. But this is your ascending colon. And then right here would be where the ileum of the small intestines meets the cecum area of the large intestines. And there's a valve right here called the Ileocecal Valve. And it's a one-way kind of valve. And then you have your appendix coming off of here. And then this is also a flexure, which is a turn, but it's called the hepatic flexure because the liver's sitting right here. So your splenic flexure is by the spleen, which is on the left side of your abdomen. The hepatic flexure is by the liver, which is on the right side of your upper abdomen. So this just kind of real fast. You guys may already be familiar with all of this, but this is really a great way to kind of get it in your mind, so that if you're just doing a proctosigmoidoscopy, they're just doing the rectum and this S part, which is the sigmoid. If they get into the descending colon at all, you have to convert it to a colonoscopy. You would not code the sigmoidoscopy. Okay, we've killed that horse. So here we go. Colon polypectomy. They thought they were going to do a sigmoidoscopy. They actually advance all the way to the cecum, so you're going to code this to a colonoscopy because of the documentation of extent. They talk about the transverse colon and descending, all of that. This is one that I was going to look up, and I might as well look it up now with you. There's several polyps that are being removed. The way that I could tell, they were all removed by a snare. That's the type. You can have cold, forceps, hot, but these were by a snare. And when you go and read the actual code that you're going to find, it's going to say removal of tumors, S in parentheses, polyps, S in parentheses, by snare technique. So you need to match up your snare technique, but you will only use one code because your CPT code accounts for multiple polyps. So there's only one CPT code here, and then your diagnosis code would be polyps, colon polyps. 8B is your path report. Pretty easy peasy. 7-9, sigmoidoscopy. They tell you that it's going to be a normal, flexible sigmoidoscopy that was done. There was no problems. They thought there were going to be problems, but there weren't. They had an abnormal X-ray, and that's what prompted them to the scope. So the scope did not find anything at all wrong. So the only way to justify this sigmoidoscopy for getting paid in this moment in time is to go back to that abnormal X-ray. And this is a kind of hard code to find, my opinion. It's kind of used a lot, but it's kind of a crappy code. Doesn't really tell you much. But once you find it, I would maybe write it down or put a star by it, or if you had a hard time getting to it, make yourself notes so you don't waste a lot of time the next time getting to it. In my outpatient charts, I actually use this code quite a bit, believe it or not, my outpatient radiology that I do. 10A, sigmoidoscopy. This is for sigmoid and rectal polyps. They're scattered between the rectum and the sigmoid colon. So they go in, there's 4 polyps that are seen, and they end up taking biopsies. So this is for biopsies. That is what your CPT is going to be, for biopsies. And then it tells you to reference down here your path report. In the real world, you would always get your diagnosis code from the path report if it's available to you. It's kind of hard and seems weird in here, black and white, you know, not having a paper chart with different dates and stuff on it, but that's kind of what they're trying to simulate. So this path report ended up giving it a benign neoplasm. There were 2 different frozen segments or frozen fragments, so make sure your path report level reflects 2. 11A, colonoscopy, post-procedural diagnosis. Remember, I always use post-op diagnosis. Ulcerative mass in the ascending colon, consistent with, and then they're not too clear. So just kind of follow that. They've done the colonoscopy. You see that they went all the way to the cecum, so you know it's a good full colonoscopy. Biopsies were obtained. That's what all of this is for a biopsy. Impression, large mass. You cannot code consistent with. That's not definitive. You cannot code versus. That is not. So it actually tells you down here that on the path report it confirmed adenocarcinoma of the ascending colon. So that's the diagnosis code that you can use. Here's your surgical consultation for this. This is a consult. 11B is. There's, in the impression, he does kind of list like diabetes and hypertension, some other kind of POA, present on admission type of diagnoses. But remember, for this moment in time, this doctor is doing a surgical consultation, and he's the gastroenterologist. He's going to be the surgeon performing any surgeries. So I would not even bother with coding hypertension and diabetes in the presence of a pacemaker, solely because this physician, it doesn't impact him at all. He's not going to be managing those things. There's still going to be a primary care doctor who will be managing those things. So there was a decision for surgery made here, so make sure you have your correct modifier for that. Do an inpatient consultation, and then the only diagnosis code that is relevant to this surgical consultation is that adenocarcinoma. I hope that made sense. This talks a little bit, this is again that kind of picture that I was telling you. It's just so helpful to kind of have the organ system in your mind. Hemicolectomy are partial, so that means only part is being taken out. There are times that maybe from here to here need to be taken out. They cut it out, and then what they do what's called an anastomosis. That's when they take this end and this end. They've already cut the middle out, and they put them end to end and sew them back together. It's called an anastomosis, when you take one end and another end, sew them together. You can use it in anywhere, but very, very common in the colon. 11C is going to be the surgery for this cancer patient. They're doing a hemicolectomy, that means half, or partial colectomy. Ectomy means removal. Post-op diagnosis, they've got a perforated adenocarcinoma of the ascending colon. We already know that. They are going to find a secondary cancer of the mesentery. So you'll find that in here. And they talk a little bit about it up in this black part. The black writing talks about the metastasis. Anytime something is metastasized, it has spread. So you would have a primary and a secondary. Your ascending colon will be your primary. The mesentery cancer will be your secondary. Path report here is 11D. It actually ends up telling you that the tumor infiltrated full thickness wall to the mesenteric fat. So that gives you that it's spread through where it's supposed to be into something else. 12A, hospital inpatient. So all of this is the hospital inpatient. This case goes on like forever. So you're going to put this patient in the hospital, so you're going to need to look at the history, determine that level, look at the physical exam, and then look at the medical decision making. If we look under assessment, I generally don't change the doctor's order too much unless it just looks like he didn't pay any attention to a sequencing. This particular one I think is sequenced fine based on what the history of present illness, what they're presenting with, and all of that. So here we have nausea, vomiting, and diarrhea. It says questionable etiology. That just means they don't know what's causing it. It's a definitive statement that they have nausea, vomiting, and diarrhea. So those would be my first two. You can find nausea and vomiting combined, and then your diarrhea is a single. They talk about gastroenteritis. They say it's unlikely, so I just blow that off. And I kind of come down. They've got hypertensive chronic renal failure. So like on the call we had Thursday, you're going to do your hypertension first, and it has to be that special hypertension. You've got 2 hypertension codes to pick from, stage 1 through 4, and then stage 5 and 6. It's not giving you a stage here. Now, it may on the next page, but it doesn't here. So you would have to use your N 18.9, and because of that, you're going to have to not use the hypertension for the stage 5 and 6. This patient is a status post kidney and pancreas transplant. And then they have hyperlipidemia as well. I coded everything on here. Well, it doesn't look like I coded the hyperlipidemia. I think I would, because they've got in the hospital, they got to continue the Lipitor. I just don't have this written down. So I also coded the status for that kidney and pancreas transplant. I think that has a direct correlation with what's going on, and it certainly affects the status of the patient. I do not think your answers have it. They have it on other parts here, but they didn't have it on this first one. So no sweat if they had it or didn't. It's just a status code. I personally felt like it impacted care. There's a little discussion here, and they're talking about it, and the histories would also be reported, but yet the answers didn't have them, so the book doesn't even know what they're doing. So that's what I would do. 12B, infectious disease consultation. Again, think about it. This patient has nausea and vomiting and has diarrhea. So you're immediately thinking either a bacterial infection or a viral infection, probably thinking virus first. So now they're having probably an epidemiologist coming in, some kind of consultation. This is a kidney and pancreas transplant patient. So there's major rejection potential issues. There's any significant sickness could potentially affect those transplant organs. This is a young kind of sick dude here. So this is a consultation. Make sure your diagnosis, your CPT code is for a consultation. Talks here about the status of the transplants. They're pulling C. diff and stool cultures here, so they're still very much looking at the diarrhea and the nausea and vomiting, which is kind of, I think maybe the nausea may have been gone by now, but the vomiting is still there. So I would do my sequencing wise, diarrhea first, then my vomiting. They do not include his type 1 diabetes, which obviously he has now because of that pancreas transplant. So I included it, and they say it's complicated by the retinopathy. I don't care too much about the retinopathy necessarily, but I think the presence of diabetes, type 1 especially insulin dependent, is significant to what's going on with this patient. The answers didn't have it. I would have coded it. I would have sequenced it third, and then I would code the status codes for those transplants. Yippee! And this one, talk about going on forever. 12C, This is a colonoscopy. I think it's the same guy. Like I said, his case just goes on and on. This is a colonoscopy. This was kind of weird from a diagnosing standpoint. They're taking biopsies. We have evidence that they went far enough for a colonoscopy. There's no problem with that. They kind of ended up having a normal colon except for patchy erythema, patchy red spots that they just kind of weren't sure. They're not going to call it anything. So I would not code this just as an abnormal finding. I think since they appear to be kind of throughout, they're in the descending, sigmoid, and rectal areas. That's hitting half of your colon right there. So I would code this to just a disease of the intestines or disorder of the intestines. Kind of generic. What I came up with was K63.9. I don't think I went back and checked the answers, so my answer may be different. I don't know. I would also, again, put the transplant codes on here because they directly talk about them here. Not sure that the diabetes matters so much, colonoscopy, because that's only one organ, but I would certainly still have those status codes for the transplants. 12D, this is the EGD right here. Their plan was to do an EGD, so now here it is here. The mild gastritis stuff has been biopsied. We still have the status of the Z codes for the transplant. They do go all the way into the duodenum or the duodenum, so it's a full EGD. Biopsies were taken, and then the mild gastritis. 12E, this is a KUB x-ray, abdominal x-ray. Remember, KUB is kidneys, ureter, and bladder. Clinical symptoms, nausea, vomiting, and diarrhea. And I think you're just kind of stuck with those. I don't think they find too much again. I don't know if your answers had the transplant status codes or not. I used them. Here's another KUB a couple of days later. Don't be putting any funky modifiers on this series of x-rays, except your professional, your 26. They're on different dates of service. If they were all on the same date of service, then we would have to modify them some way, but they're on different dates of service, so it's okay. They're also inpatient, which further makes it okay. And then you have your discharge summary here. You've got small bowel obstruction, etiology to be determined. That doesn't mean they don't have the obstruction. They're just not exactly sure what's causing it. Dehydration, acute renal failure, your status codes for transplant, and then a diabetes type 1. Some of this other stuff, there's a history of asthma. I don't know where that came from. Minimal history of CAD, your metabolic acidosis and electrolyte imbalance. That was symptoms of the acute renal failure, so I would not code them since we have the acute renal failure. If we didn't have the acute renal failure, I would, but those would be symptoms of the acute renal failure. So remember, from a CPT standpoint on discharge summaries, you have 2 codes to pick from based on time. This gives me 30 minutes, so I know it's the 99238. So you've got your intestinal obstruction, your dehydration, your acute renal failure, your diabetes type 1, and then you have your 2 status codes. And if you got all that, you're doing good. 713, completely different patient. We are done with that 32-year-old really sick one. This is an appendectomy, laparoscopic, and then they had to convert it to an open appendectomy. If any of you know ICD-9, there's a code for that conversion. There is not a code for that conversion in 10. So don't get that confused. If you don't know 9, don't worry about what I just said. Complications, there was a small tear, so when they were doing their laparoscopic first part of this appendectomy, they ended up poking a hole, so they had to convert it to open procedure and pull and finish it off there and sew up where the injury was, or they call it injury, where they punctured the hole. So CPT-wise, you have 3 codes. One is for the excision of the appendix. One is for the enterorrhaphy. Let's talk about that word. Rhaphy is the end part of the word. That means sewing up, suturing. Entero means intestines. So that's where they sewed up the puncture. And then you have your diagnostic laparoscopic procedure. And the reason we get to code for that diagnostic laparoscopic procedure is because there was a significant chunk of this procedure that was done laparoscopically, and it was through the laparoscopic procedure that we got the puncture, so we can't just leave that off. It has to be documented. So I would put a 59 modifier on that, and I would put it last. Now, diagnosing wise, we have what did they call it? Acute appendicitis. Thank goodness. I was afraid there's another one that it's a weird appendix, but this is an acute appendicitis. Then you have the complication intraoperative puncture. And then you have an injury code to the intestines. That S code, which is the injury code, is further describing that intraoperative complication that they did. Remember your S code when you get the injury for the intestines, you're going to have an A for your 7th character because this is the initial time that that injury is being addressed. Whew. Got through that one. I was scared about that one. 14A. This is a cholecystectomy. Chole meaning gallbladder or cholecysto. Cysto means bladder. Chole is describing which kind of bladder. So a cholecystectomy, ectomy meaning removal or excision. So cholecystectomy is a removal of the gallbladder. They say that the diagnosis code is biliary dyskinesia. That means the bile is not moving out like it should. Dyskinesia means a difficulty moving. And biliary is obviously either in the biliary tree or in the actual gallbladder itself, which kind of holds our bile. They tell me that they've done a laparoscopic cholecystectomy. I don't trust anybody, so I have to kind of look and make sure that it really is laparoscopic and not open, because that's a big difference in the CPT codes. So as I'm looking, I see them talking about ports, and I see the abdomen was insufflated with carbon dioxide. That tells me they inflated. That insufflated is a word that you would always use laparoscopic wise. You would not use that typically open procedure. And then they talk about removing the gallbladder here. So it's good to go for that. And I would use a diagnosis code of biliary dyskinesia or dyskinesia biliary, however it crosswalks. 15A, outpatient consultation. Consultation outpatient for a non-healing gastric ulcer. Non-healing may very well convert to chronic in your diagnosing. So kind of be aware of that. 15B, this is the emergency room record for this. So your CPT will be emergency room. It is for abdominal pain, for a gastric ulcer. And I was looking to see if they were calling that ulcer non-healing or chronic. I don't see it, but I am kind of perusing it fast. Under the subjective, they do talk about this patient has gastroesophageal reflux disease or GERD. I would code that as well. I don't think your answers are going to have that. But this is directly abdomen related. Your gastroesophageal is gastro or GI related. Some of this other stuff, the COPD and stuff, that doesn't affect this particular ER record at all. If they're admitted, they would be POAs or present on admissions, but this is just an ER. Real world, we'd probably pick up everything, but I'm teaching you what the board's going to expect. 15C, outpatient consultation. They are preparing for a pending gastric resection. This is a non-healing peptic ulcer disease. They're trying to rule out some of this other stuff because it won't heal, but because it's a rule out, we cannot code it. It has to be a definitive diagnosis. She is a cigarette smoker. I think that certainly affects the care of this patient from an ulcer, non-healing ulcer standpoint. I do not think your answers pulled out the ongoing smoking. I did. So this is an outpatient consultation, the chronic or non-healing ulcer, and then I coded the F17.200 for the ongoing smoking. It's not a status code. She hasn't quit it. He says here he's wanting her to possibly cut, or him, whoever the, I don't know the sex of this person, to cut down. 15D is the ulcer and cholecystitis operation. This is now they're saying it's a non-healing duodenal ulcer and chronic cholecystitis. They do a partial gastrectomy. They do a vagotomy, truncal vagotomy, otomy meaning incision, and then they do the cholecystectomy with an intraoperative cholangiogram. So what I do, I don't sit and just read every little thing. You guys may need to, maybe starting out, but I don't. I kind of peruse. If I'm looking to justify these procedures, then all I'm looking for is to pull out the documentation that they were done. I don't really care all the minute specificity or specifics of this surgery. So in the procedure, they're talking about an ulcer here. They dissected it. I'm good with that. Over here, we proceeded with truncal vagotomy, so that proves to me they did it. Dissection was considered continued posterior to the stomach, the ulcer, so they're still working on the ulcer. It does put it down in the duodenum. Our next step was to proceed with the cholecystectomy, so that's good for me. I think it's been done. And then they talk about the intraoperative cholangiogram. And so just that little bit proved to me that these 3 procedures that I had pulled out had been done. This gastrostomy, that one is so hard for me because it's the gastro and the jejunum of the small intestines, but ostomy is a surgical creation or a surgical hole creation of a hole, and they did do that in here, but it was integral to what they were doing with everything else. So I didn't code that. They did nothing with it. Had they put a tube in it or something, then we might be cooking with gas, but they didn't, so I didn't. Okay, so then the findings kind of go over what I just talked about. So you've got your partial gastrectomy, your vagotomy, and your cholecystectomy. Your diagnosis codes is that duodenal ulcer and your chronic cholecystitis. Whew. Here is the intraoperative cholangiogram that was done. That's probably the easiest part of the whole thing. 15F. This is the path report of this surgery. They highlighted stuff. I didn't do anything in here. They highlighted stuff in here. You can read what they highlighted and how many pieces of tissue they have. There is an intraoperative section here, so you're going to have that code. I ended up with 3 specimens of 88305, and then I had my ulcer 88307 and my gallbladder 88304. So just kind of, I get it that I just gave you the answers, but maybe you can go backwards if you were having trouble with it. Maybe you already did it, or you don't want to hear my answers. If you don't, you better go backwards. But that's what I came up with. And then I also have the intraoperative with those 3 intraoperative sections. So there's 3 diagnosis codes, and they give them to you right here. So they did a whole lot of highlighting and giving to you in this one because it's pretty complicated. So we'll just call it good. Here's the discharge summary for this one. Obviously, I don't even have answers. I guess I skipped it. Shame on me. If there's no mention of time, it's just going to be your 99238, non-healing duodenal ulcer, chronic, and your chronic cholecystitis. So it's probably a repeat of your diagnosis codes. 16A, we have a cystectomy. This is post-op diagnosis, right descending sigmoid colon area mesenteric cyst. A lot of times when you see cyst, it actually converts into lesion in our CPT, so kind of keep that in mind. This ends up being a benign neoplasm of the mesentery. 17A is a hemicolectomy. This is a perforated adenocarcinoma of the ascending, much like the last one or a few back. Looking under the actual procedure, I see that during dissection of the cancer from the lateral abdominal wall, the cancer was firmly adherent. So it's adhered itself to several different structures. They end up having to take out that whole structure, which is the hemipartial colectomy, and then they do an end-to-end anastomosis. So the colon and ileum were then transected, taken out, and then they did an anastomosis of the ends that were left in. So your CPT code is going to be a partial colectomy with the ileum involved. And then you've got two different diagnosis codes, and they kind of give them to you here. You've got your primary of the ascending, and then your secondary of the abdominal wall. 18A, initial hospital. This one's kind of tricky. I'm kind of not happy. They've done this a couple of times in the book now with this 2016. If you look at the physical exam, there isn't much there. So in order to have an actual level to put a patient into the hospital, you have to have at least a detailed examination. The doctor did not supply that, so there's nothing, and you have to meet all three components. So from a CPT standpoint, this doctor is not going to get credit at all for putting their patient in the hospital. Real world, you'd query the doc and have him provide an addendum with the physical exam, because hopefully he's done it, hopefully. For us, we just don't code it because there's not enough to code. Your diagnosis code is, there's a complete bowel obstruction, so that's what you're going to code. 18B, same patient. Here are your diagnoses in the post-operative diagnosis here. They talk about taking down the adhesions. They talk about all of this is going to be one CPT code because it's a complete small bowel obstruction. A whole lot of wordy stuff for one thing. The adhesolysis, or the setting free of the adhesions, are bundled in. If you went to look at that code, it's going to say separate procedure. So whenever you have a big dog procedure, your separate procedures are usually bundled into that. They talk about an internal hernia. So from a diagnosing standpoint, you've got three different diagnoses, but from an action or a CPT standpoint, you just have the one big dog that took care of everything. Your discharge summary here. This one I had to kind of write my, there's no mention of time, so you know what your CPT is, but I had to kind of come back over here. I hate it when the pages are turned like this. The patient was in for that small bowel obstruction. That would absolutely be my sequencing. I would put it first. That's the whole reason for the admission. Then you've got a fistula there. I would not code the acute respiratory distress simply because they're not in it now. But there is a failure to extubate. So this patient is leaving dependent on a ventilator, which means they're not in acute respiratory failure because they're ventilated now. So I would code the Z code, Z99.11, for dependence on ventilator. That would be my last code. So before that Z code, I would do the CAD, or the atherosclerotic heart disease. This one was kind of weird. Okay, 19A. We're almost done with this chapter. 19A, this is a gastrostomy and a tracheostomy. Patient has Crohn's disease. They're now ventilator dependent. So you're going to need that Z99.1 for sure, but it would always be sequenced after any other real code, what I call real code, because it's a status code. Okay, so we are, what procedure are we having done? So we are having a tube placed and a tracheostomy. Yeah. So here they're entering the colon. They're having elective exploration, placement of a feeding tube, and then a tracheostomy. So they talk about puncturing the transverse colon, air leaked out. They're talking about an anastomosis, clear fluid. They made a gastric opening and then put in the gastrostomy tube. So that's that tube being put in. Then you've got your tracheostomy. Let me see. Okay, yeah, so here now they're going back to, they're up looking at the thyroid. They're checking for placement. They're looking at the first tracheal ring. We placed the tracheal retractor, divided the second. This patient is on chronic vent anyway, so they're doing the tracheostomy so that it's more comfortable for him. He can eat and drink, and potentially if you know. So from a you've got 3 CPT codes. From a diagnosing standpoint, you have the complication of an intraoperative puncture, and it kind of tells you over here what happened. Then you have their Crohn's disease, because that affects one of the body organ systems that they're working on, and then you have your vent dependence. This one was difficult to me. 20A, appendectomy for acute appendicitis. Talks here that the appendix was delivered up and into the wound, so all you have to do is determine if this was an open or a closed procedure. And I'm going to let you figure that one out. Remember, if it's a closed procedure, it would be laparoscopic, and they would talk about trocars and ports and insufflation, that kind of thing. So 20B is the pathology report for that appendectomy, and this is the one that was weird. It says acute appendicitis here, but when the path report comes back, it says, well, there's no evidence of inflammation. So you're stuck with an obliteration. There is fibrofatty obliteration of the appendix. So if I were you, I would go to obliteration in the index of the ICD-10 and find it that way. Just saying, that'll save you some time. 21A, inpatient, putting them into the hospital. Mass of the right lower quadrant. They have a UTI because of E. coli, and they have hypertension. Easy peasy. 21B, this is a cystectomy. So this is taking out part of the cecum of the intestines, large intestines. Inflamed, ruptured appendix with mass palpable in the cecum. So there, and they say possibly cancer. We don't know that yet. It ends up being a benign mass. So an action standpoint or a service code or a CPT, all the same thing, is your partial colectomy excision and then your appendectomy excision. Diagnosing, you've got your mass, and you have your appendicitis with, wasn't there appendicitis with peritonitis? It was performed, it was difficult, mass was inflammatory or not. I think maybe I got, so they had a benign mass, oh, ruptured appendix, that's what it was, ruptured appendix, so it is appendix with peritonitis. I thought I saw that. And then here's your discharge summary on this patient. Oh my gosh, we're almost done. And it's a super duper long discharge summary. I mean, like freaky long. So get your CPT. It's good to get. And here we've got to talk a minute about the diagnosis codes because there's just so much stuff in here. So remember this patient. He was put in the hospital for the acute appendicitis with perforation. So that's number one. I would do number two, probably the next most important out of all of this is going to be that hypertension with the chronic renal failure and acute renal failure. So you're going to have 3 codes for that. Remember your hypertension, I-12 code has to sequence in front of the CKD. That's according to our guidelines. Then we've got our respiratory failure, and some of the, you can kind of list these in any order. Once you get that first or second one in, the order doesn't matter. So you've got your post-op small bowel hernia, you've got your complication of obstruction, and you've got your anemia up here, and you have your UTI with the E. coli. So there's a whole lot going on. I came up with 9 different diagnosis codes, but I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 actual codes because your urinary tract infection with E. coli is 2 codes. You got to do your UTI and then your E. coli. B code. It's a B code, like boy. 722, placement of a gastrostomy tube. This is a modifier 78 because this patient, he was previous in something, but he's in the post-op period and he's having to have a gastrostomy tube placed. So put a 78 modifier. I think maybe I got that from the black stuff. Yeah, okay. They're telling you it's during the post-op period. So here you see your enterotomy, otomy, incision, enterointestines. So that's one of the CPT codes. So they did an enterotomy and then they placed the tube. And there was a obstruction somewhere. Look for an obstruction in here. Yeah, that the point of obstruction was not at the anastomotic site. So, and the anastomosis appeared wide open for the patient. So there's an obstruction in here. There's the enterolysis going on in here, and there's also the tear. Or multiple tears have to be repaired in the small intestines. I believe the obstruction said it was a volvulus. I shouldn't code these and then sleep because there's different kinds of there was marked dilatation of the small bowel, and we began taking down multiple adhesions. That's your adhesolysis. There were multiple incidents of serosal tear due to the marked dilatation of the small bowel. So the doctor didn't do anything wrong. The mucous membranes of the bowels, serosal lining, is just tearing because it's so blown up because of the volvulus. I think it's a volvulus. There's a twisting in here. I gotta keep reading. You guys should be reading this too. Entire bowel lysed, so they set it free. The enterotomy into the bowel was repaired in 2 layers. They placed the gastrostomy tube. Stomach was tacked. Oh, this poor person. They just did a whole lot of stuff. So I have 1, 2, 3, 4 CPT codes with my only one, yay, ICD-10 code, which is the obstruction, the volvulus obstruction or the twisting. And I got that somewhere. I'm telling you, I couldn't just pull that out of my head. Well, I could, but hopefully I didn't. So you guys can tell me if I coded that wrong. I don't think I did, but I may have. 23A, insert inpatient. This is a right inguinal hernia being put into the hospital. This one is a breath of fresh air, much, much easier. 23B is the correction or the surgery for that hernia. Remember, with your hernias, you want to know if they're inguinal, if they're ventral. You want to know, are they strangulated or incarcerated, the same thing, or if they're reducible. I think that's it. Oh, and age. You need to know age. Hello. And here's the pathology report. Oh, also keep track of if it's the left side or the right side, if it's inguinal, because there's mirror images of those. 24A, surgical consultation, umbilical hernia. This is a consultation decision for surgery, so use that modifier. Here is the op report, umbilical herniorrhaphy. Let's talk about that word, herniorrhaphy. Rhaphy meaning suturing. Hernio, obviously a hernia, so they're suturing the hernia. They are saying that they are able to reduce the hernia, so I would make sure that you pick a CPT code that has reducible. And 25A, there's just a couple more, thank goodness. 25A, op report, axillary node dissection. That's what they did here. Talks about multiple enlarged lymph nodes were identified and excised, removed. All lymph nodes that could be found were removed and sent to pathology. So this is a lymph node excision. Since it's axillary, that's mirror image, so track your left or your right. And they end up saying, not here, but if you turn the page on the path report, it ends up being non-Hodgkin's. There's also an intraoperative frozen section here. 26, splenectomy, idiopathic thrombocytopenia purpura, or ITP. So they are removing the spleen. That's kind of an easy code to find, just a total spleen removal for idiopathic thrombocytopenia purpura. Your pathology report backs that up, and it's just the spleen. So just plug your spleen into your different levels and find your level. 27A is a bone marrow biopsy. Thank goodness we're out of digestive now. Bone marrow biopsy for anemia, acute renal failure, and some skeletal pain. The skeletal pain we aren't necessarily gonna code. Bone marrow aspiration and biopsy were done. You will need 2 codes for this, one for the biopsy, one for the aspiration. You will need to use, and I meant to look this up too, there's a 53 modifier on this one for a discontinued procedure. And the reason they did that, over here he said, I attempted to obtain bone marrow aspiration from the right posterior iliac crest and was unsuccessful. It was dry, so wherever he tapped in, he couldn't aspirate anything. I went over to the left and was able to obtain some bone marrow aspirate with some minimal or moderate discomfort. I would imagine it was moderate or more. These I've had this done, is terrible. So your 53 modifier is, I would actually write this, your 38220 worked good. So it's the left side, no, it's the right side that was unsuccessful, your left side worked. So they've actually put the 53 modifier on the left side. I think this is a mistake for them. So I would put the 38220-53RT and 38220-LT, because the left side is where it was successful. So put the modifier on the side that it was not successful and it had to be discontinued. There's been a hole, an injury created on that patient on that side, so we have to kind of track that. We had to do 2 holes, one on each iliac crest, so it has to be tracked. So the one that failed has the 53 modifier on it for discontinued procedure. And then your diagnosis codes. And they put, oh, the diffuse skeletal pain, I think that ends up sequencing maybe to bone disorder or bone disease. It's something super duper generic, M89.9. Strange. Okay, 28, bone marrow biopsy for acute myelogenous leukemia. Make sure that your diagnosis code is specific to this type of leukemia. Also, this is again on the iliac crest, so track your left or your right. Oh my gosh, we're done. So now you are into, oh, what a terrible picture. Now we're into our auditing, and then we'll start musculoskeletal next.